All right, guys and gals, let's continue our discussion on the ovarian and the uterine cycles. Collectively, both the ovarian and the uterine cycles are referred to as the menstrual cycle. If we look at the ovarian cycle, it starts with that female gonad, the ovary. Each ovary is going to contain many follicles. A follicle you can think of as a small structure within the ovary that contains an oocyte, or an egg. Most follicles are going to be immature in nature, or they are not going to be fully maturated. So they're going to be itty-bitty, itty-tiny follicles. When a female reaches puberty, she has about 300,000 to 400,000 immature or primordial follicles in her ovaries. During the lifetime of a female, approximately 400-ish of those follicles will mature. And that implies that over the course of the female's reproductive lifetime, she will have about 400 menstrual cycles that she'll go through. Once a follicle mature, or one follicle will typically mature once a month. Every once in a while, if you're on reproductive therapy, if the female's on reproductive therapy, or just by gosh, by golly, you'll have more than one follicle maturing per month. This happens until menopause. Menopause is the end of both the ovarian and the uterine cycles, or more formally, it's going to be known as 1 year without having any menstrual cycle at all. Ovulation is going to be the release of a secondary oocyte, commonly just referred to as an egg in colloquial speak. This happens once a month once per menstrual cycle when the ovary, the mature Graafian follicle on that ovary will rupture. Sometimes females are capable of feeling the exact popping of that follicle as a small twinge in the lower abdomen. That's referred to as a Misselherz pain. Occasionally females can feel that. As we look at this figure, the figure will be just a little bit different looking from what's in your textbook. Primarily, I switched these two around, the corpus luteum and the corpus albicans. I switched around. So we can see we have our primary follicles with our primary oocytes in them, and then they grow larger. The oocyte and the follicle grows larger and larger, and until we have our mature Graafian follicle forming, and then that follicle will release a secondary oocyte. After that secondary oocyte is released from the ovary, the leftover tissue from the follicle turns into a structure known as the corpus luteum, and that corpus luteum is going to release some very important sex hormones, progesterone and estrogen, that help to maintain the lining of the uterus, the endometrium, also known as the endometrium, so that the potentially fertilized secondary oocyte, or fertilized egg, can implant. If there is no fertilization, conception does not occur, the corpus luteum will become smaller and shrivel up to become a corpus albicans, and then eventually it will shrivel up even smaller and no longer be present. It'll be a small cyst on the ovary. This the primary oocyte, pictured right here, has 46 chromosomes. This is going to be at the beginning of oogenesis. And it will have 46 total chromosomes, and it will go through meiosis. During the process of meiosis, we go from a diploid cell to a haploid cell. And this primary oocyte, during meiosis, will release a first polar body. And the actual cell that's ovulated is a secondary oocyte, pictured right here. And when a sperm penetrates that secondary oocyte, we finish meiosis, and the last polar body is released from oogenesis. So to actually have an egg, we need to have the sperm penetrate. And for a very, very brief period of time, that second polar body has been released, but the nucleus of the sperm has not fused with the nucleus of the egg. Once those nuclei have fused, fertilization has technically occurred, and we have a zygote formed. A zygote is a single cell that is alive and has a unique human genome. During the ovarian cycle, there'll be a formation and release of an immature egg. This immature egg is called the secondary oocyte. The whole process of our ovarian cycle is going to be controlled by a very specific hormone called GnRH, or gonadotropin releasing hormone. This hormone comes from the hypothalamus in the brain, and if we look at, here's a brain, a mid-sagittal slice of the brain. The hypothalamus is located right here, and directly inferior to the hypothalamus, we have the pituitary gland. That gonadotropin releasing hormone goes from the hypothalamus to the anterior pituitary gland, and from that anterior pituitary gland, that anterior pituitary will release luteinizing hormone and follicle stimulating hormone. Follicle stimulating hormone specifically causes the follicle to grow larger. Luteinizing hormone triggers ovulation. We also find that the follicle-stimulating hormone is also going to stimulate the production of estrogen. As we have the production of estrogen occur in the ovary, early on in the ovarian cycle, low levels of estrogen inhibit the release of these hormones, but around mid-cycle, around day 10, the slightly increasing concentration of estrogen all of a sudden causes a positive feedback loop, which causes there to be a spike in luteinizing hormone. And that spike in luteinizing hormone triggered by estrogen is what initiates ovulation. After ovulation, the corpus luteum, the leftover tissues of the follicle, will release both estrogen and progesterone. And this corpus luteum will release low levels of estrogen. The low levels of estrogen released by the corpus luteum after ovulation will inhibit GnRH production and inhibit GnRH reception. And the progesterone also has a similar function as well on the hypothalamus and anterior pituitary gland. The progesterone and estrogen also serve to maintain the lining of the uterus. The two main phases of the ovarian cycle can be broken up by ovulation. Day 14 is when ovulation occurs in that idealized 28-day cycle. So before day 14, we have the follicular phase, when the follicle is growing. After day 14, after ovulation, after the corpus luteum has formed, we have the luteal phase. If pregnancy does not occur, menstruation will typically begin at day 28 and reset the menstrual cycle. This 28-day event that occurs in the uterus, or 28-day cycle that occurs in the uterus, is known as the uterine cycle. This corresponds to the 28 days of the ovarian cycle. During the beginning of the uterine cycle, days 1 through 5, we have menstruation occur. There's low levels of estrogen and progesterone, and these are very low levels cause the inner lining of the uterus, also known as the endometrium, to slough off or disintegrate. And after days 6 through 13, the endometrium regrows, it regenerates itself. So the increasing levels of estrogen from days 6 to 13 of the ovarian cycle causes the endometrium to thicken within the uterus. Day 14 is ovulation in the uterine cycle, in the ovarian cycle, and day 14 helps to separate the proliferative from the secretory phase. During the proliferative phase of the uterine cycle, the endometrium is growing much thicker. During the secretory phase, the endometrium grows even more thick, and it also is going to have the development of some glandular secretions known as uterine milk that are going to develop within that endometrium. If that egg is not fertilized and implanted, the corpus luteum is going to get smaller and smaller on the ovary, and there will be less and less estrogen and progesterone being released from the ovary, and that will cause the uterine cycle to reset. So here we can see the hormone levels from the ovarian cycle and the events of the ovarian cycle being overlaid with our hormone levels, or I should say the hormone levels from the anterior pituitary gland, and then our hormone levels from the ovary. And these can be overlaid with the events happening on the ovary and the events happening in the uterus. So at day 1, through typically day 4 or 5, there's menstruation occurring. So there'll be some sloughing off or bleeding of the endometrium from the uterus. And this corresponds to low levels of progesterone and low levels of estrogen. As we have low levels of follicle-stimulating hormone, the follicle grows larger and larger and larger and will increase ever larger levels of estrogen. Eventually, we switch over from a negative feedback loop where low levels of estrogen inhibit the release of luteinizing hormone to a positive feedback loop where high levels of estrogen promote the release of luteinizing hormone. So once we switch over from that arbitrary low to high concentration, we have a spike in luteinizing hormone, which shortly causes an event known as ovulation. So when the follicle is being ovulated, or when the secondary oocyte ovulates from the primary follicle, we switch from the follicular phase to the luteal phase. So we go from having a follicle to a corpus luteum on the ovary. And then in the uterus, we go from the proliferative phase to the secretory phase. This corpus luteum that's on the ovary is going to start secreting progesterone, and progesterone will maintain the endometrium and cause the endometrium to grow even thicker. But if fertilization and implantation does not occur, the endometrium The endometrium of the uterus will become thinner and thinner as the levels of hormones become lower, and eventually it will start sloughing off again. If fertilization occurs, we will have a sperm and egg nuclei fusing to form a zygote. Typically, fertilization is going to occur in the oviduct, also known as the uterine tube, also known as the fallopian tube. So let's back up here. Here we go. So here we can see a uterus, and right here is that oviduct or uterine tube. So fertilization will typically occur right here, and then the fertilized zygote, or fertilized egg, will travel and get embedded on the side of our uterus, on the side of the endometrium. After that fertilized egg has been implanted, that officially is the beginning of pregnancy, because at that point in time, we will find that we'll have increasing levels of human chorionic gonadotropin, or HCG. So pregnancy typically is going to occur about 6 days after fertilization, or more specifically, will typically occur on day 14 is ovulation, and that egg is fertile for a day. So pregnancy can occur on day 21 of the uterine cycle, or of the menstrual cycle. Here's some good information for you, just in terms for family planning purposes. The egg, or the secondary oocyte, will be ovulated around day 14 of the ovarian cycle, and this secondary oocyte is capable of being fertilized for 24 hours. If it does not come in contact with sperm during that 24-hour period, it will just pass through the female's reproductive tract, and the cycle will reset itself. So, class concept check. Which hormone directly causes ovulation? Go ahead and pause this video or rewind it, or check your textbooks, whatever you need to do to get me an answer. 5, 4, 3, 2, 1. Alrighty, the correct answer is D, luteinizing hormones, the one that directly causes ovulation. Moving on, let's talk about birth control methods. There's the classic, don't have sex, abstinence. If you don't want to have children, a great way to not have children is to not have intercourse. You've all learned about the birds and bees. This one is a no-brainer. But there's some other methods of birth control as well. We have hormonal-based birth control pills. These hormonal-based birth control pills typically will use low levels of estrogen and or low levels of progesterone to block follicle-stimulating and luteinizing hormone from being released from the anterior pituitary gland. We can also have these hormones injected, or there could be a not a UTI, that's a urinary tract infection. There can be a contraceptive implant put in the uterus that will have low levels of these hormones to help prevent ovulation. We find that if we want to prevent the transmission of a sexually transmitted disease, or STD, that the only ways to do that are abstinence, so just don't have sex and you won't get a disease associated with sex, or some kind of barrier method like a condom. This could be a male or female condom, and typically these need to be latex-based condoms to work appropriately. As we look at our barrier-based methods, an IUD can be implanted in the uterus. Some IUDs prevent implantation. Those are going to be the copper-based IUDs. Most IUDs, though, are going to be a piece of plastic with some hormones supplementing them. And those IUDs are going to rely on preventing ovulation. We also have condoms. There are those male and female condoms. And then we also have the diaphragm, which is a latex cup that can cover the cervix and prevent sperm from entering the cervix. If you are all done having kids and you are positive, you don't want to have any more kids, you have the option of getting sterilized. You can have a vasectomy if you're a male. That's going to involve cutting the vas deferens. Or if you're a female, you can have a tubal ligation. Your uterine tubes can be cut and sealed. So, as we see here, we can have an intrauterine device. To me, these always look like microscopic diatoms or sea creatures. And these intrauterine devices are shoved in the uterus, and they prevent ovulation and or implantation. Sometimes, depending on what your personal moral beliefs are, if you believe that human life begins at conception, you will absolutely want to talk to your healthcare provider about getting an intrauterine device that prevents ovulation as opposed to preventing implantation. For both female or male condoms, those prevent sperm and egg or secondary oocyte from coming in contact with each other, and most individuals are absolutely okay with those forms of birth control pill in terms of moral objections. During sterilization, as I mentioned before, we cut some tubes. So we have the vas deferens being snipped for the males, or the oviducts being snipped for the females. Oh, as a heads up, if you have a tubal ligation or if you have the vas deferens snipped, generally speaking, you want to wait about 6 months to make sure that there's no sperm left in the male's reproductive tract. And the general guideline is to wait a couple months for the female as well. So even if you just had the surgery done, you still continue using other forms of birth control for up to 6 months, just to make sure there are no lingering gametes in the reproductive tract. There are also some pills that can be taken after intercourse. These are commonly referred to as the morning after pills. The two main morning after pills are Preevin and RU488, or also known as mifepristone. These two pills function to make the lining of the uterus, the endometrium, unacceptable for that fertilized egg to implant in. The first one, Preevin, is 85% effective if it's taken the morning after intercourse. RU486 is 95% effective. And these pills have a few moral implications. For individuals that do not believe life begins at conception, there's absolutely no problem with these pills. But for the group of people that do believe that humanity begins at conception, they have a couple issues with these kinds of birth control. There's an in-between group of people that believe that your humanity begins when you are when the zygote at that place, the blastomere, is implanted in the lining of the endometrium. And for that group of people, the morning after pills do not provide any ethical objections. We can also have infertility. Infertility is a very common problem among U.S. couples that are trying to conceive. There are multiple things that contribute to infertility. Currently, in the United States, a little bit over 10% of couples are struggling with infertility. Generally speaking, infertility is going to be formally defined as the inability to have children, or I should say the inability to conceive and have a pregnancy after a year of unprotected sex. And I need to emphasize here that this is unprotected, that penis penetrating the vagina intercourse with the male ejaculating inside of the vaginal canal. Every now and then we'll have individuals performing oral sex on each other, wondering why they aren't conceiving and having a child. So it's important to emphasize this unprotected intercourse of the penis penetrating the vagina. There are several causes of infertility. Common ones can include, that's actually not even mentioned here, just can be sperm-egg incompatibility. Sometimes the sperm and egg are incompatible with each other. A lot of times they can be because the gentleman has a low sperm count. To treat low sperm counts, many times the gentlemen are going to have some hormonal supplements and also will switch their underwear and lifestyle habits. If the female has a lot of abdominal adipose, that could prevent the egg from getting into the uterine tubes. If we have a blocked oviduct, which can occur because of a uterine infection, that could also prevent fertilization from occurring. Or we could have inflammation of the lining of the uterus. We could have endometriosis. And if that lining of the uterus is inflamed, it's not going to be a suitable place for the fertilized egg to implant. So if somebody's infertile, what options do they have? Well, there's adoption. You could adopt somebody else's baby. That's the classic one that's been done for thousands of years. There are some new methods, though, that have been developed in recent years, though. We could have artificial insemination by a donor. This is when you take sperm from somebody else and insert it in your vagina when you are ovulating. This can be done by a trained physician. Sometimes there's some mail order kits that are kind of sketchy, but I've heard some stories about women doing that. We also have in vitro fertilization. This is going to be a human egg coming in contact with a human sperm inside of a test tube or in glassware. In vitro means in glass. So in vitro fertilization is fertilization inside of some kind of laboratory glassware. After fertilization, the embryos are transferred to the woman's uterus. We also have gamete intrafallopian transfer. In this situation, the egg and sperm are placed directly inside of the oviducts immediately after they've been brought together. You could think of this one as in vivo fertilization. Effectively speaking, the sperm and egg are going to be joined and will fuse together, practically speaking, inside of those uterine tubes or oviducts. Another one, this is actually kind of an old school one, a surrogate mother. It's a woman that's legal that will have your baby for you. And in ancient times, the infertile woman would take her handmaiden and have her handmaiden sleep with her husband and conceive for her. That typically doesn't happen very much in westernized countries anymore. Now typically what we'll have is in vitro fertilization, where the mom and the dad will have their gametes combined and then implanted inside of a woman who has donated the use of her uterus to incubate the child and have the child grow. We also have intracytoplasmic sperm injection. In this situation, we'll take a single sperm from the male and inject it directly into the egg. In this situation, we typically will only resort to this if the male has a low sperm count. Generally speaking, this is a little bit trickier, and it's easier to just take tons and tons of semen with tons and tons of sperm and squirt it around the egg and let bygones be bygones, so to speak. Just let one of the sperm randomly fertilize the egg. There are some pros and cons to treating infertility. If we look at the surgery and collection of eggs from the woman, they have some risk associated with them. There could be some organs damaged. The uterus, the ovary, the uterine tubes can be damaged during this process, and there can be some side effects such as heavy bleeding. If we look at the fertility drugs that can be taken, they have some very significant side effects. There can be multiple ovulations, and you can end up with a situation where you have an octomom, for example. Some of the complications related to fertility drugs are potentially life-threatening, particularly the increased risk of cancers and or blood clots. If we look at in vitro fertilization, fertilization in that test tube, there are many embryos created. Depending on your particular moral viewpoints, if you do not believe life begins at conception, generally speaking, this is a non-issue for you. But if you do believe that human life begins at conception, then this is a very significant issue for you. What happens with the extra embryos that were fertilized but not implanted in the female's uterus? Do you donate them to somebody else so that they can have your genetic child? Or do you destroy them? Or do you use some other purpose for them? Typically, you harvest a stem cell line from them. We find that there's definitely a significant increase in multifetal births. In other words, triplets, twins, quadruplets, so on and so forth. And this multiple birth pregnancies are very difficult for mom and for the children that are growing inside of the fetus. So some big issues that need to be asked is what happens to the frozen embryos the leftover frozen embryos after IVF. This is a fairly contentious issue. And then we should also ask ourselves who should be and who should not be treated. Recently in the news, I heard about a woman who was 50 years old who gave birth thanks to IVF. There are women that occasionally over the age of 60 will give birth to IVF. Is there a maximum age that we're willing to say as a society that no, you are too old to give birth to a young child? We will not allow for you to have these infertility treatments. This is a very personal, very intense decision for many women, and this is something that needs to be discussed, and a consensus needs to be reached on this. And there's no way I'm touching that with a 10-foot pole in this lecture recording. I just want to make you aware that these are some of the potential complications that need to be discussed. So, guys, gals, let's have a concept check. Which methods of birth control prevent the spread of STD, sexually transmitted disease? This is one where you need to select all that apply. We have intrauterine devices, the withdrawal method, a condom, abstinence, sterilization, the morning after sex pill, or hormonal birth control pills. Go ahead and pause this video and give me an answer. 5, 4, 3, 2, 1. The correct answers are condoms and abstinence. The barrier method of a condom or just not having sex are the only two methods that prevent the spread of STDs. All of these other methods, while they may prevent fertilization or pregnancy, they do not prevent the transmission of STDs. Also, it's worth emphasizing that oral sex either fellatio or with the penis entering the mouth, or I forget the term for the labia entering the mouth. Male or female oral sex or anal sex. While they don't result in pregnancy, they still do result in the transmission of STDs. Let's go ahead and end this recording. If you have any questions for me about the material that was covered, please feel free to post them in the discussion board, shoot me an email, or swing by my office when you're on campus. Happy studies.